Hi, today we're going to discuss a case of a partial retreatment of a maxillary first molar. And for those of you who aren't familiar with the term partial retreatment, let me explain it with an example. What you're looking at here is a picture of Superman saving a child from a running train. But what has happened in the process is the tracks have been damaged, the front part of the train is crushed, probably a few other passengers inside the train have been injured as well. A simpler way of saving the child would have been just to carry the child out of the way of the train. So, this is exactly the rationale behind partial retreatment, which is doing exactly only what is required to get the expected outcome. So, now let's analyze this preoperative radiograph. What you can see here is a palatal canal that is not so adequately filled, a little periapical radiolucency in relation to it as well, a fairly well filled distobuccal canal, and a mesiobuccal that is about 3/4 filled. So, what is going to be the plan for this case? The plan when it comes to partial retreatment is largely going to be based on what the patient's complaint is. So here in this case, the patient's chief complaint is sensitivity. So whenever a patient complains of sensitivity on a root canal treated teeth, the first thing I would do is look at the adjacent teeth for proximal lesions and cervical abrasions, which probably have been accidentally mistaken for the sensitivity in the root canal treated teeth. So once these two factors have been eliminated, that is exactly when I start thinking of the root canal treated teeth. And when a patient complains of sensitivity to hot and cold on a root canal treated teeth, the answer is very straightforward. It is pulp tissue remnants. And especially when it's on a maxillary first molar, the MB2 canal is the first thing that we have to think of. So what we do now is an exploratory access to see what we can find. As discussed earlier, we can see some evidence of necrotic tissue present adjacent to the MB canal, which is the missed MB2. So according to everything that I've mentioned earlier, what I've done here is I've gone ahead and cleaned and shaped the MB2 canal. Now another very big question arises. The doubt that arises is, do you treat the MB canal also along with the MB2? So here's what I follow as a thumb rule when it comes to these situations. If the mesiobuccal and the mesiobuccal second canal are independent, I am not very particular that I treat the MB also. But in case they are confluent, I would definitely go ahead and clean out the MB as well. So this is the image of the mesiobuccal and the MB2 canal, cleaned and shaped. They are ready for obturation, but when it comes to retreatment, I'd love to always give a antibacterial dressing, see how the patient is doing, and then go ahead and obturate them. So that's the finished post-operative radiograph with the MB and the MB2 canal well obturated. A few of us might still have the doubt as to what happens if the patient develops a problem in the palatal or the distobuccal canal. The answer to this is again very simple. When you are proficient in using a microscope for your retreatment, it is very easy to go through a prosthesis and exclusively treat the problem area alone. Let me show this again with an example of another maxillary first molar which I retreated. So this again here is a maxillary first molar and the patient was referred to us with pain. So we decided to take a CBCT. The CT report showed that the patient had a lesion in relation to all the root canals. Interestingly, the mesiobuccal and the distobuccal canals were fused. So here we decided to retain the crown and treat all the canals through the existing intact crown. As you can see, very little amount of the tooth structure or the crown has been removed to gain access to these canals. So there is absolutely no reason for changing this crown even in the future. So that's the finished post-operative radiograph. We completed this case in a couple of visits and at the end of which the patient absolutely had no symptoms at all. So that brings us to the end of this presentation. And for those of you who are interested in knowing more about endodontic retreatment, do attend our 2-day workshop in New Delhi on the 11th and 12th of March. And for more information on this workshop, have a look at the next slide.